Thanks for joining us. We're proud to offer regenerative pain medicine training, ultrasound workshops for regional anesthesia and interventional pain, online training as well, and board prep for pain docs, anesthesiologists, physiatrists. Check out the Virtual Pain Fellowship if you're interested in learning more about pain management, getting trained online for ultrasound guided interventions, regenerative pain medicine therapies, as well as our extensive question bank. It's the ultimate resource for pain management board prep.
Okay, so this is Dr. Vodapalli, who is one of my assistants. He volunteered to help me create some of the slides, so I'm giving him credit and respect. And by now, he's attending. Flat ankle sprains are one of the most common injuries in the foot. You get the anterior tibial ligament, followed by the subsequent calcaneofibular ligament, and then the posterior talofibular ligament. There are three grades of sprains. Grade 1, ligaments are slightly stretched without macroscopic ruptures or instability. Grade 2 is moderate, in which the ligaments are partially ruptured with moderate pain and inflammation, and the patient has difficulty supporting themselves. Grade 3, in which the ligaments are completely ruptured with severe pain, edema, hematoma, and where there's inability to function with instability. Most lateral sprains of the ankle of an injury can be handled with the plastic cast or below the knee semi-grid support, and there's great benefit with immobilization for periods of time, 10 days, or with extended periods for 3 to 4 weeks, 3 or more weeks. But extended immobilization can also cause muscle atrophy, problems with the joint and ligaments. For the last decade, PRP has been widely used to treat orthopedic lesions, and it's been reported in the literature that to be treated for ankle sprains in high-performance athletes. In ligament tears, PRP can promote positive effect on tenocytes and culture, increasing proliferation, cell migration to the ACLs, for example, with revascularization, reinnervation. In the ulnar collateral ligament, there was an effect of 90% success rate in one study. Another study that 11 patients, low-grade 3 ankle sprain, treated with PRP, and the recovery period was 5 weeks, while 90% of them went back to sports in 6 weeks, which is quicker than the norm. So there is evidence to support PRP is better than just immobilization alone. So they evaluated the return to play in athletes, and they found that in these patients there was a benefit with the PRP. This is level 2 evidence, which is pretty decent. Osteochondral lesions make up 70% of the acute ankle sprains and fractures, and it's picked up upon MRI, and biologic augmentation, including PRP, concentration, BMAC, is becoming more popular to treat it, and this is fairly common. You can read about this on your own and what the manifestations are, and you can do conservative therapy like every other problem, steroids or PRP. They found PRP does promote the recovery, and it's actually an adjunct to arthroscopic microfracture surgery. With that surgery, it does cause some fracture and inflammation that then promotes the healing as well. Here they did PRP and hyaluronic acid for the talar osteochondral lesions with microfracture surgery. It's a prospective randomized controlled trial. They found although PRP and HA injection both improve clinical outcomes for patients, PRP only required a single dose, and it's recommended that PRP used as a primary adjunct in the talar osteochondral lesion postoperative period. Here they combine PRP, arthroscopic microfracture surgery, the treatment, and they also have that comes in just the surgery alone. They said, as I mentioned, inadequate rehabilitation in some of the patients is a limitation of the study, so just keep that in mind. And it's also a relatively short follow-up, so just be having your references. So bone marrow stipulation is a reparative procedure to stimulate the release of mesenchymal stem cells from the subchondral marrow. I don't do this, so I'm not the world's expert on this. In BMS, unstable cartilage, the calcified layer, and the chronic bone are debrided arthroscopically. I imagine orthopedics do this. A microfracture pick or small diameter drill is used to penetrate the subchondral marrow. Several clinical studies demonstrating that 85% of patients undergoing it had good clinical short-term, mid-term outcomes, but there was not enough data in the literature to really assess the long-term outcome of this.